Welcome to today's CE presentation, where our vision is to bring nutrition to life for the people who live it. Financial support for this presentation was provided by Nestle Health Science. The views expressed herein are those of the presenter and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented and is for educational purposes only, and is not intended as a substitute for medical advice. Without further ado, it's time for our moderator to take it from here. Sit back, relax, and enjoy the presentation. Welcome, everyone. My name is Yvette Gaughan. I'm a medical affairs manager with Nestle Health Science, and I am thrilled to introduce today's speaker and moderate our Q&A session for the presentation entitled Nutrition Showdown, Enteral versus Parenteral, which is best for my patient. I am thrilled to introduce our speaker today, Dr. Matthew Bechtold. He is the Section Chief of Gastroenterology and Professor of Clinical Medicine, practicing general GI and nutrition at the Harry S. Truman Veterans Hospital and University of Missouri in Columbia. He has published nearly 400 articles, books, chapters, and abstracts in outcomes research, nutrition, quality improvement, and preventive strategies. He is involved in multiple national societies and serves on numerous national committees as a member and chair, including co-chair of Aspen's Enteral Nutrition Committee. He has delivered over 300 presentations, including major conferences on topics in gastroenterology, nutrition, and quality improvement. His passion lies with educating and empowering healthcare professionals to perform substantial quality improvement projects to improve systems or processes to enhance patient outcomes. It is my pleasure to turn it over to Dr. Bechtold.
Thank you so much, Yvette. I appreciate that introduction. And I'd like to thank Nestle Health Science for allowing me this opportunity to talk to you a little bit today about enteral versus parenteral nutrition, which is best for my patient. Well, my speaker disclosure, I am definitely a paid speaker of the Nestle Health Science Institute. Let's talk about a little bit more in depth. What we're going to cover today in our objectives, we're going to differentiate between enteral nutrition and parenteral nutrition feeding methods, including a lot of the indications and contraindications, which is what we want to know. We're going to explain the potential complications associated with EN and PN and how to mitigate these risks through management techniques and apply the evidence-based recommendations to medical condition and gastrointestinal function when you transition from parenteral nutrition to enteral nutrition. Now, as you all know, with any lecture that I give or talk that I give, I start thinking about other things halfway through. So objectives not covered. Why is Greenland covered in ice and Iceland mostly green? If you're in France and order toast, do you get toast or is it French toast? Why do you always find things in the last place you look? I tell you what, if you continue looking after you find it, then that's odd in itself. Why do people have worthless junk in their garage and leave their expensive car in the driveway? Makes no sense to me. Why do banks charge you an insufficient funds fee on money they already know you don't have? That seems extra cruel to me, but we won't cover those today. We're going to cover more on EN versus PN. Let's talk a little bit about malnutrition. We all know from working with this our whole lives and dedicating ourselves to the nutrition field that malnutrition is common. It does affect all age groups and settings. It is associated with poor patient outcomes and definitely may require supplemental feeding. So when we talk about enteral nutrition versus parenteral nutrition or peripheral parenteral nutrition, it's good to kind of look at where these things are given. If you're doing enteral nutrition, you can give it most commonly is the nasogastric tube. So it's a tube going from the nose and into the stomach, versus a nasal jejunal tube, which is through the nose down to the small bowel, past the ligament of Treitz into the jejunum. You can do a G tube, which is very common. That's your percutaneous endoscopic gastrostomy, your your radiologic gastrostomy and your surgical gastrostomy. These are tubes that are from the outside that go directly in the stomach. And your J tube, these are jejunostomies. These are usually surgically placed in the small bowel. Then you've got, on the other side, you've got your parenteral nutrition, which is usually given through a central line, or a port, which is on the through one of the big veins and ends at the superior vena cava, right at the junction of the right atrium. Or you can have peripheral parenteral nutrition, which is through an IV. Can be used for very short term. It's not that stable. You much rather have a central line per se to really help with given the parenteral nutrition. This was a great algorithm that was formulated by Pat Worthington in the paper "When is Parenteral Nutrition Appropriate" in 2017. I really like this algorithm. It really cuts to the chase on enteral and parenteral nutrition decisions. So what you want to do is you want to assess your patient, see if they're malnourished or not. Then you want to see if there's nutrition support indicated. And then you want to look, does the gut work or does the gut not work? Okay. If the gut works, meaning there's no contraindication in enteral nutrition. And what are the contraindications in enteral nutrition? Well, severe hemodynamic instability, severe ileus, severe nausea, vomiting, so they're not going to get anything up with diarrhea, severe upper GI bleeding, bowel obstruction, major GI ischemia, or high output fistulas. Those are your most common contraindications to enteral nutrition. If you don't have a contraindication, then you can start supplemental enteral nutrition. And you can look, is your GI function compromised or non-compromised? And that tells you which kind of formula you want to go with. And then you look at feeding tolerance. Are they able to handle the enteral nutrition and do just fine? Or even are they able to take oral diet and be just fine? So you got ways to constantly assess and move down the algorithm. On the other side, if you do have a contraindication to the enteral nutrition, you could try parenteral nutrition. And you could base this on, do you need short-term or do you need long-term? Do you need peripheral PN? It's a very short-term, not very stable. Or you need long-term, which you need a central line and central line access. And then I always say, look at the function. Are you gaining enteral function? Is the gut starting to work again? If the gut's starting to work again, ask yourself, is an oral diet okay? And if they can't, maybe we can start bringing in some enteral nutrition and try to wean down the parenteral nutrition. And we're going to discuss a lot of this throughout this talk. But to be honest with you, this slide is great. And if I just presented this slide, that's the whole talk. That's how you determine if enteral parenteral nutrition works. So that'll be all for today's presentation. We can't go any further. You want details. Okay, so we're going to give details, okay, on why some of this is like it is. And we're going to start with the enteral side and looking at the enteral nutrition itself. So there was a consensus statement started a long time ago, back in 2018, where Aspen got an enteral nutrition task force together, a bunch of very smart people that let me tag along and be part of this. Then that went to the Aspen Enteral Nutrition Committee in early 2020. They came up with 8 enteral nutrition questions that were plaguing everybody's mind clinically on when can we use enteral nutrition or not. We submitted a manuscript to JPEN in 2021, and in 2022, it was published. And this is that paper, When is Enteral Nutrition Indicated? And we're going to talk a lot about what those 8 questions were to really determine when you can give enteral nutrition. Let's start off by asking the simple question, what is the optimal time frame to initiate EN in the high-risk nutrition patient, the malnourished patient, and the stable, well-nourished patient? Well, if you look at the data, we all know that early EN has an impact. To the degree we're not quite sure, but we know there's an impact on mucosal integrity, immune modulation, and downregulation of the systemic inflammatory response, or SIRS. TN did a study in 2018, did a systematic review of 16 randomized trials that really showed that early EN reduced mortality compared to delayed enteral intake. But The problem with this is they didn't really specify the timing very well, so there's a lot of variation on that. Bally in 2016 did a meta-analysis on 22 randomized trials that showed nutritional interventions show a significant reduction in non-elective emissions. Then we get to our bigger trials. You know, our Nutria 2 trial showed that full feeding may impose potential harm due to gastrointestinal complications, especially ischemia. So it's something we got to watch out for. Then you had Dr. Rice at Vanderbilt looking at the Eden trial that showed that trophic feedings, which is about 15-25% of the calories, versus fully in for the first 6 days in acute lung injury, showed there's no difference in mechanical ventilation days, infection mortality. So we're saying that maybe trophic feedings is the way to go to get the benefit without having the harm of ischemia. So we took all this data and we put it to the experts and said, well, what do you think? What's the optimal time frame? Well, came up in those that are, you can initiate enteral nutrition 24 to 48 hours after admission in those who are in an ICU who are a high-risk nutrition patient or malnourished patient. So that's very important. So you can start early, okay? You can delay enteral nutrition in patients who are low risk, well-nourished, and expected to probably have some type of oral intake within 5 to 7 days of admission. So you got about 5 to 7 days you can wait on those who are well-nourished. You can advance enteral nutrition cautiously in those who are at risk at refeeding syndrome. Of course, someone who's coming in who's severely malnourished, be careful and watch the electrolytes, especially phosphorus, potassium, magnesium, and watch how they're doing with intolerance when they come in such a starvation state. So this is a good thing. So in those who are high risk, we're talking about 24 to 48 hours, you can initiate enteral nutrition. In those who are well nourished and low risk, 5 to 7 days. So what are the indications for enteral tube feedings in the oncology patient? Now we looked at a lot of things when it comes to this, and you know, the routine use of enteral nutrition in chemotherapy is not recommended. We don't just automatically say you're going to get chemotherapy, let's give you enteral nutrition. That's not how we do it. You may be doing enteral nutrition in those cancer patients who have pre-cachexia, cancer cachexia, and are severe malnutrition refractory to oral intervention. There was a study in 2014 that looked at how common is malnutrition in these cancer patients, and it found that in head and neck cancer patients, almost 50% have malnutrition. Lungs, 45%. Leukemia, lymphoma, 34%. So we know it's there. We know that they have a lot of malnutrition. So we really got to be cautious and watch this when these cancer patients come for nutritional support. So what do we look at when we're trying to make up some type of consensus statement on this subject? Well, we looked at the ESPEN guidelines of 2016. We looked at the ASPEN guidelines in 2009. And we looked at the NCCN clinical practice guidelines in oncology in 2017. So we've got some guidance on which way to go. So when we did this, we determined that you can use enteral nutrition on oncology patients who have solid tumors who are unable to take at least 60 to 75% of their goal nutrition intake orally, and who present with moderate to severe malnutrition. You can also use enteral nutrition in patients unable or expected to be unable to take over 60% of calories or protein needs by mouth for a greater period of 7 to 14 days. Some of these patients are really sick, so they might not be able to eat very well for 7 to 14 days. You can consider post-pyloric short-term access or jejunal tube in those with refractory nausea and vomiting, which is very common in chemotherapy, or those with other intolerances to adequate gastric intake. You can consider early aggressive enteral therapy for patients pre-cachexia and cachexia if the intake is inadequate. And you can consider symptom management to maximize oral intake in patients with refractory cachexia, life expectancy less than 3 months, or a Karnofsky performance status less than 50, or those who do not wish to continue cancer treatment. So that's more of a palliative thing. So you can give them oral intake and see how they do. What are the indications for enteral feedings in patients with GI diseases? So we can't pick all GI diseases, but we picked the ones that were most common. Inflammatory bowel disease, Crohn's, ulcerative colitis, chronic liver disease, very common for malnutrition, and acute pancreatitis. Now that includes both mild, moderate, and severe pancreatitis. So we looked at guidelines. For inflammatory bowel disease, we looked at the ESPEN guidelines from 2017 and the Cochrane Database Systematic Review 2018, looking at induction and maintenance. For chronic liver disease, we looked at the ESPEN guidelines 2006 and the Cochrane Review in 2017. And in acute pancreatitis, we looked at the International Pancreatic Task Force Consensus Guidelines in 2012 and also the AGA guidelines of 2018. So what did we find? Well, we found that enteral nutrition is indicated in a variety of patients with GI disease, but not just limited to the ones we tested, when the patient is at risk or has emerging malnutrition due to inadequate oral intake. We found that enteral nutrition as a therapeutic option for the induction of remission in Crohn's. Now, this is a little tricky because enteral nutrition can induce children who have a Crohn's flare into remission, but not so well with adults. Adults still steroids are much better, where a study showing in kids that enteral nutrition and steroids can be almost equivalent in inducing remission. So we also showed that enteral nutrition is indicated in preference to parenteral nutrition in patients who have predicted severe acute pancreatitis. Now, you notice I said severe acute pancreatitis. These are your sick patients. These are the ones in the ICUs. These are the ones with multi-organ dysfunction, multiple problems. It is safe to commence enteral nutrition within 48 hours in patients that have stabilized somewhat who have this severe acute pancreatitis. Now, I know that there's been a lot of randomized trials too that have shown that the timing may be okay to start early, may be okay to wait, but for right now, I think starting enteral nutrition within 40 hours has shown that it stabilizes some of the gut mucosa and stabilizes the surge response a little bit better. First line, of course, is the nasal gastric tube. We used to put nasal jejunal tubes in all these patients, but for now, many studies have shown that the nasal gastric tube works just as well and has the same outcomes. Now, if the patient has severe nausea and vomiting or bad gastroparesis, then you might consider a nasal jejunal tube because the food won't go, the tube feeds won't go anywhere if you have bad gastroparesis. Polymeric formula is the first choice in severe acute pancreatitis. So what are the indications for enteral feedings in patients with specific non-GI diseases? So we picked a few, such as CVA, cerebral vascular accident or strokes, cystic fibrosis, chronic renal disease, and COPD. For strokes, we looked at the AHA Stroke Council guidelines from 2019, ESPEN guidelines 2017, Cochrane Review 2012. CF, we looked at the ESPEN, ESCAN, ECFS guidelines 2016, Cochrane Database 2017. Renal disease, ASPEN guidelines 2010, so that probably needs to be updated. And COPD, we looked at the A&D ASPEN ESPEN guidelines, the conglomerate 2021, and the Cochrane Database 2012. So there's a lot of different sources that kind of guide us on some of these diseases. So the key takeaways here is you got to evaluate all stroke patients for dysphagia as early as possible. Initiate EN using a nasogastric tube in stroke patients that are deemed unsafe for oral intake, because a lot of these patients have oral pharyngeal dysphagia or inability to move food from the mouth into the esophagus. So there's a lot of different muscles that are working coordination to move things through, and patients who have strokes, a lot of those muscles don't work like they should in the past, or they're not getting the neurological input to work, and things can pool and they can aspirate. You can consider a placement of a gastrostomy tube in those who have the inability to swallow safely for 2 to 4 weeks. Now, this could be a predictor too. If you predict your patient's not going to be able to swallow for 2 to 4 weeks, that could lead us to put in a percutaneous endoscopic gastrostomy. The issue we have here is when I have patients who have strokes and they're on the NG feeding, and the team calls me and asks for a PEG after 2 days. Okay, so I want to give the patient a little bit benefit of the doubt and see if they can go a little bit longer on the NG feedings and be able to tolerate an oral diet before I can have to put in a PEG. In cystic fibrosis patients with malnutrition who are unable to meet their nutritional needs with diet and oral supplements alone, you can initiate the EN. You can also initiate EN in malnourished chronic kidney patients who are unable to meet their demands by oral alone. This includes patients who are not on dialysis and patients who are either intermittent hemodialysis or on even peritoneal dialysis. You can initiate EN in a malnourished or at-risk chronic obstructive pulmonary disease. So these are your COPD patients, and we know multiple studies show that COPD patients are malnourished, and if you do put them on some type of nutritional support, they actually, breathing gets better. I mean, it's never going to be great, but breathing gets better, and their FEV1 and output parameters on their pulmonary function test actually get better. So when to initiate early EN in hemodynamically unstable patients? This is probably the biggest question I get from my ICU staff and dietitians in the units. So we're going to spend a little time kind of covering this because it can get a little complex. So if you look at the different vasopressors versus ionotropic agents, okay, the vasopressors, all of them tend to reduce GI blood flow. If you reduce GI blood flow, it's hard to take a lot of nutrients from the gut into the system. They're increasing the mean arterial pressure, and sometimes the cardiac output increases, but not all the time. So keep that in mind, depending on what agent you're using to get the blood pressure up. Now, if you're using ionotropic agents like dobutamine or milrinone, they definitely increase GI blood flow because they're increasing cardiac output. So everything's going everywhere as best as it can because it's at a chronically low state. So what's the big question here? Well, people thought that if you have enteral nutrition on a vasopressor, that leads to bowel ischemia. Well, there's a study by Sabino in 2021 looked at 319 ICUs in a retrospective manner and really found the incidence of bowel ischemia when you add enteral nutrition with vasopressor is relatively low. It's 1% or about there. The biggest issues they found was they use gastric residual volumes of greater than 300 milliliters as a sign of intolerance. And as you see, it was more often found with vasopressors than no vasopressors. But the other symptoms, emesis, new onset abdominal pain, bowel ischemia, either by an operative report or CT scan, were pretty equivalent between the two. Now, I say this with a caveat. The caveat is you've got to be able to recognize signs of bowel necrosis or bowel ischemia. If your patient has sudden massive abdominal distension, pain, bloating, cramps, high nasogastric tube output, any signs of ileus, intramural gas, hypotension, tachycardia, or I like to refer to as funky bowel sounds. If they have a lot of funky bowel sounds, that could be an indicator of problems with the enteral nutrition in this population. So you definitely would have to back off at that time. But you can do it. You just have to kind of monitor and make sure that you don't push it too far. Mansell 2013 did a retrospective study. It was just one ICU, but it was 259 patients looking at different vasopressors and enteral tolerability with enteral nutrition and that vasopressor. And shocking enough, most folks tolerate enteral nutrition with a vasopressor. Over 60%. Or about there. Vasopressin was the lowest at 59%, but epinephrine and norepinephrine were 66 and 74% tolerability. So patients do tolerate this. And what did they define as enteral intolerability? Gastric residuals, of course, greater than or equal to 300 cc's. Emesis, positive finding on a normal bowel imaging. Evidence of bowel ischemia or perforation. So that's what they said. Well, that's the line we're going to draw. If they have that, then we won't push anymore. But generally, most folks will tolerate enteral nutrition on a vasopressor. So then we looked at, some great guidelines written by Stephen McClave and a lot of great smart people. Guidelines for the provision and assessment of nutritional support therapy in the adult critically ill patient. And after their big review, they looked and then found that enteral nutrition may be administered if the mean arterial pressure is greater than 60, but probably should be held if the mean arterial pressure is less than 50. And this really comes back to, is the gut even getting perfused? Once you get below 50, not only is the gut likely not getting perfused, but a lot of other organs are not getting perfused as well. So we try to keep that map above 60 as much as possible. Well, what about ECMO? ECMO is extracorporeal membrane oxygenation. You can do veno-atrial, which is heart and lung support, or venous-venous, which is lung support. OB in 2018 did a retrospective study in Japan looking at early EN is not associated with harm in ECMO patients and actually lowers mortality in patients with cardiogenic or obstructive shock requiring at least 2 days of ECMO. McGowan in 2019 in London said, adequate energy and protein delivery during veno-venous ECMO is possible. Underfeeding is very common, so these patients likely need some type of nutritional support while they're on ECMO. So the bottom line is, when do we initiate enteral nutrition in these hemodynamically unstable patients? Well, I hope you have been watching and listening and understand that the vasopressor administration is not a contraindication to providing early enteral nutrition, as long as you have careful monitoring. Now, the next 7 bullets are the same thing you hear on pharmaceutical commercials, where the family's laughing and having a great time at the park while all the bad side effects are being listed real quickly underneath the tone of what you're seeing. So, of course, you have to always think about the vasopressor agent, the dosing, the timing, the location. Is it trophic only, or do you hold EN if the vasopressor dose equivalent dose is greater than 12? Do you initiate EN within 48 hours of vasopressor initiation, depending on the dosage? Gastric feeding is definitely preferred. There's insufficient data to look at lactate levels and monitor it. Although routine gastric residual volumes aren't recommended in critical illness, if you do measure them, it's reasonable to hold the enteral feedings in this population if the GFVs or GRVs are greater than 300. And again, as I said before, you can administer enteral nutrition if the MAP is greater than 60, but hold it if it's less than 50. And when you're feeding on vasopressors, I'd probably use a 1 to 1.2 kilocal per cc higher protein, lower fiber formula. And you can initiate EN within the first 24 hours of ECMO support. I'd probably start more at a trophic rate, especially early, and monitor for a response. And continue through the ECMO, even in the prone position, because there is some evidence that it does help long term. So that was a tough subject. I give you that. The hemodynamically unstable patient is definitely a tough concept, and people are very nervous and anxious when it comes to putting enteral nutrition in patients who are hemodynamically unstable. So let's move on. Can patients be fed with when undergoing paralytic therapy? This is good. We had an actual ESICM guidelines by Blazer and a lot of smart people here too that looked at early enteral nutrition in these critically ill patients, and they came to the conclusion that you do not need to hold or delay enteral nutrition in patients undergoing paralytic therapy. Now, the same caveat also exists that you have to monitor them for intolerance or problems down the way. And if they do have problems, then you can make adjustments and hold the enteral nutrition at that time. What about, can patients be fed on BiPAP or other non-invasive ventilation treatments? Well, based on the SSCM guidelines, the ESPN guidelines, and the Cochrane review of 2015, and based on common sense, decision to start enteral feeding when they're on non-invasive ventilation should be multidisciplinary, meaning you probably should talk to your ICU folks and your pulmonologist, and made on a case-by-case basis. And the reason why is because if you're trying to put a tube to the nose or the mouth, whatever type of enteral feeding tube you're using that's not a gastrostomy or jejunostomy, then it's going to interfere with the ventilation mask, whether it's BiPAP or CPAP or whatnot, and it's going to cause air leak. And air leak is a big problem, so you might need special adapters or sealing pads or something to kind of prevent that. So if you are choosing to enterally feed a patient on non-invasive ventilation, they do kind of think, well, can you do post-pyloric placement to where you have less of an aspiration risk? I mean, the last thing you want on these patients who are having lung injury and very difficult time breathing is last thing you want is for them to aspirate. So if they have any type of risk of aspiration, probably go post-pyloric feeding with an NJ tube rather than NG tube. So what are the indications and strategies to use for catch-up feedings? Okay, this is a big problem, and we all know this in the hospital. We have patients, they need feeding, they need nutrition, but they're always going for tests. And all these tests, including everything we do in GI, they always have to be MPO for a certain many times, and by the time they get it, and the time they get delayed on the test, sometimes they get it within 30 minutes, sometimes it takes 3 hours, and then they just lost 3 hours. So based on the SSCM and ASPEN guidelines in 2016 and SOCGEV in 2020, looking at a prospective study of 227 patients, you really can use a volume-based feeding protocol over the old conventional hourly rate protocol. Improves the amount of calories of enteral nutrition they get per 24-hour period. And you could consider patient condition factors in formulating the feeding regimen to promote the amount of energy that you need to get to maximize the amount of calories they get. I just want to give special props to Leah and Peggy. This is a great article in case you haven't got it. In the New England Journal of Medicine, just released April 2025, last month. A great article, a reviewing of a lot of the big trials in nutrition, and the use of enteral nutrition in hospitalized patients. It's a fantastic read. If you haven't read it, I highly suggest it because they did a great job. And congrats to Lee and Peggy for such a wonderful study. All right, well, let's talk a little bit about parenteral nutrition. We go back to our handy dandy formula, and this is for the patients who are malnourished, who can't maintain an adequate diet orally, and who cannot have enteral nutrition for whatever reason. So we're going to hit parenteral nutrition. And when should PN be initiated? Now, again, I go back to this great article by Pat Worthington and crew in 2017, and they did a fantastic job. It was a good conglomerate of kind of answering some of these tough questions. So I want to reiterate that if you have a gut that works, use it. That's my mantra. That's what I like to do. I think it's better for the patient. I think that's what most of us will want. But what happens when you can't have a gut and when you have contraindications to enteral nutrition, such as I mentioned before, severe hemodynamic instability, severe ileus, nausea, vomiting, diarrhea, severe upper GI bleeding, bowel obstruction, major GI ischemia, high output fistulas. These are the big contraindications where you got to think to yourself, well, I have a malnourished patient, they don't do oral, I can't give that much enteral nutrition or any at all because they have a contraindication. Let's try parenteral nutrition. So if you have a patient who's well nourished coming in, you can initiate PN after 7 days for these well-nourished, stable patients who are unable to receive a significant amount, which is 50% or more of estimated requirements by oral or enteral nutrients. So For well-nourished, it's 7 days. If you have a nutritionally at-risk patient, you can initiate parenteral nutrition within 3 to 5 days if they cannot meet oral or enteral nutrition parameters. So, nutritionally at risk, 3 to 5 days. What if they're baseline moderate or severe malnutrition? Then you can initiate PN as soon as it's feasible for patients with this type of baseline moderate severe malnutrition whom oral intake and EN is not possible. You may want, some do, delay the initiation of PN in a patient with severe metabolic instability until the patient's condition is improved. So you might have to wait a little bit just to make sure all the electrolytes and everything seem to stabilize a little bit, blood pressure stabilize a little bit before you can start the parenteral nutrition. So in well-nourished, it's 7 days to start PN. Nutritionally at risk, 3 to 5 days. For baseline moderate severe malnutrition, as soon as feasibly possible. Okay, makes sense? What about perioperatively? Well, you can consider preoperative PN in those who are severely malnourished, unable to tolerate sufficient oral intake or enteral nutrition. You can also reserve post-operative PN for severely malnutrition patients unable to tolerate EN for more than 7 days, unless initiated preoperatively. So in those patients who you think are not going to be able to tolerate for a week or more, that might be a subject for post-operative PN. Palliative care for PN, you should not use PN solely to treat poor oral intake or cachexia associated with advanced malignancy. You should limit the use of PN in palliative care to careful selected candidates. Expected survival more than 2 to 3 months or oral intake or EN is not feasible. You have to evaluate clinical factors and performance status when selecting these candidates for PN at the end of life. And you always, always, always want to involve the patients and caregivers and give clear and complete dialogue regarding the goals. What are the realistic goals of parenteral nutrition, as well as the potential risk and burdens of therapy? This is a big thing that I have a disconnect between what the family thinks and what reality really is. And not only does it apply to, I always give my fellows a lecture on PEG tubes and the reality versus family. But in this case, in parenteral nutrition, it's the same way. They see it as a way of feeding, but maybe it's not the best way because there's a lot of potential risk and burdens of therapy. So you really have to be open and honest with the family and present both sides, not just one. So let's talk a little bit about what do we do with people who are on parenteral nutrition, but maybe, just maybe, you want to move them to enteral nutrition. Why? Why would we even do this? Well, we know that enteral nutrition may promote improved gut function, restore the gut microbiome, avoid prolonged PN complications such as intestinal atrophy, dehydration, electrolyte, all kinds of problems, infections, especially from the lines, liver complications, blood sugar fluctuations. And you also, the big one that's come up a lot recently in the past 2 years is reduced dependence on product or IV shortages, whether it be something in the TPN that we don't have anymore, or whether it's IV fluids that we don't seem to have anymore thanks to a hurricane. So what are the problems? And this covered a lot. This is a great look at this. It was by Klaus in 2002 in Clinical Nutrition that looked at PN versus EN, and this also includes oral well. What are the problems you have when you're trying to move someone from parenteral nutrition to a different type of nutrition? The illness plays a role. Are the patient's too weak or too fatigued to eat? Lack of appetite, there's pain. Transition could be a problem, due to dry mouth with no saliva, lack of appetite, taste is changing, early satiety, eating fears, abdominal pain with enteral nutrition. Got to look at the organizational aspect, portion sizes, meal quality, communication between teams, which is very important, and also some other things like decreased monitoring, lack of information instruction, medication side effects, fear, stress. So there's a lot of things that go in to addressing when you're trying to move from parenteral nutrition over to either enteral nutrition or oral therapy. So what are your strategies? So how are we going to do this? What are we going to do? So if you have someone on parenteral nutrition, solely. You really want to assess the GI function periodically. And I'm not saying every day, but at least every week, try to figure out, where you're at and do you have a GI function if they're in the outpatient. If they're in the inpatient, it might be every day trying to figure out if they have GI function. If they do have GI function and based on no symptoms, like vomiting, cramping, stool distension, residuals, look at a physical exam. Is the abdominal distension better? Bowel sounds improved? Ascites gone or reduced? Tenderness less? And diagnostic imaging. Is the imaging showing better? Labs better? Endoscopy plus or minus, depending. And GI motility tests you may need. If you're constantly assessing their function and looking for these things, and they look like they may be able to tolerate enteral nutrition, I say initiate enteral nutrition. You can initiate at a very low rate and increase it over 48 to 72 hours, and constantly monitor for refeeding syndrome. Remember, the bowel has been in a state of atrophy for a while if they've been on TPN. So if you start nutrition, go slow and really monitor for refeeding syndrome. Always monitor and adjust. Maybe you're increasing the enteral nutrition. At the same time, you could probably bring it down the parenteral nutrition. So you're kind of always doing that balance to bring it down. And if you reach your enteral nutrition goals of at least 60% of calories and protein over a 48 to 72 hour period, I say you can completely transition them off of parenteral nutrition. Now that caveat's being said, unless they have to have a lot of IV fluids for whatever reason. But this is a way that you can assess GI function. These are the things that you're looking at: symptoms, physical exam, diagnostic testing, things that you look at to make sure that their GI function is okay. And to reiterate this point, we're going to go through a case. This case is a 60-year-old female with history of ileocolonic Crohn's disease, status post, quote, a very difficult, end quote, partial ileal resection about 40 centimeters 5 years ago. Presents to the ER with severe diarrhea for 3 weeks with right lower quadrant abdominal pain, which progressed over the last 48 hours to no stools or flatus, generalized abdominal pain, and vomiting times 48 hours. Over the last month, she's lost 15 pounds. Physical exam reveals a fatigued appearing 52-kilo female with very diminished bowel sounds, abdominal distension, generalized tenderness to palpation. Labs show potassium at 2.9, albumin at 3.0. CT of the abdomen shows ileal thickening with significantly dilated loops of small bowel. Patient admitted to the hospital. What to do? Now, I hope you realize from reading the case that this patient, and I'm going to hit the highlights here, this patient is a Crohn patient likely with a bowel obstruction, and probably a complete bowel obstruction by what it sounded like on CT. Now, that is a contraindication to enteral nutrition. So, but the patient, as you see, is very malnourished, 52 kilos, losing weight recently, having all kinds of problems. So they're a malnourished patient who looks like they have a contraindication to enteral nutrition. Also, as a side note, I put in there that patient had a, quote, very difficult partial ileal resection. That means that the surgeons had a rough time last time, and no other surgeons are going to want to go in and play if they don't have to. So they're kind of wanting to do more conservative management. So what do? NPO, NG tube for decompression, IV steroids, fix the electrolytes. Okay. After 3 days, patients still having abdominal distension, nausea, vomiting with minimal bowel sounds. Electrolytes have been corrected. NG tube still in place with the low intermittent suction. What do? Well, in this case, they're severely malnourished, and they still have a contraindication to enteral nutrition. They have stabilized in their metabolic problems with the electrolytes, so we can start parenteral nutrition due to the contraindication to EN. After 8 days, patient's nausea and vomiting is resolved, and she's passing flatus. Bowel sounds present, distension has resolved, electrolytes have been normalized. CT of the abdomen shows only mild thickening in the ileum with no dilated loops of bowel. However, she's still unable to take in any meaningful oral intake. Still a little nausea, nausea is resolved, but still unable to take in no desire to eat, doesn't want to take it in at the moment. So what do you do when you have that case? Well, you can switch the NG tube over to a feeding tube, an NG feeding tube. Steroids can be switched to per tube instead of IV, and you can start enteral feeding. You can start slowly and monitor for refeeding syndrome. Remember, she came in severely malnourished, so we definitely want to monitor for refeeding syndrome and monitor for intolerance like we talked about before, and slowly taper the parenteral nutrition as the EN is increasing. Finally, after 12 days, patients improved significantly and able to tolerate oral diet, meaning 75% of its caloric goals. So that means she's above that 60%. So now we can probably wean off and take off the parenteral nutrition altogether. And now she's able to tolerate an oral diet. So what do? Well, at this point, we can start her on an oral diet. We can discontinue the feeding tube and we can discharge home on an oral diet, and hopefully put her on some Crohn meds that'll try to keep this bowel obstruction from happening again. So we covered a lot of information. I threw a lot of stuff at you real quick, a lot of timing and a lot of different indications and contraindications, and we went through them pretty quickly. So in summary, malnutrition is common. We know this, we showed this. The mantra is, if the gut works, use it, because there are benefits to having enteral feeding and using an oral diet relative to parenteral nutrition. Initiate enteral nutrition as early in high-risk patients. It may be required in cancer patients, but it has to do with a lot of talking with your patients. It may be helpful in inflammatory bowel disease, chronic liver disease, acute pancreatitis, cystic fibrosis, chronic kidney disease, COPD. It's possible to use enteral nutrition in patients on vasopressors, ECMO, and paralytics, but you got to watch it carefully. You can do enteral nutrition in non-invasive ventilated patients, but you got to be careful about the seal, and sometimes you have to have certain types of equipment to make it work right. Catch-up feeding improves enteral nutrition received. Parenteral nutrition may be initiated in certain circumstances. We cover that quite a bit. And the transition from parenteral nutrition to enteral nutrition may be possible on an individual basis. So I'd like to thank everyone for the time. I'd like to thank Nestle for the time and Yvette for monitoring. I may have some time for questions. Thank you all for joining us.
Thank you so much, Dr. Bechtold. We really appreciate it. Love your hometown girl here.
So one of the questions is, fiber-containing formulas on vasopressors. Again, you try to want to do a lower fiber when you're on vasopressors, because you're just trying to avoid anything that could bulk up the bowel even more and cause more intolerance. And even, with me, who don't take enough fiber in my life, if I get a fiber 1 bar or 2, it really bloats and makes me intolerant of a lot of things, okay? So you want to try to avoid those high fiber things and try to go with a low fiber diet when they're on vasopressors. Now, when they're off the vasopressors, you could go a little bit more of the fiber and push a little bit more, because it does have some health benefits of the colon, so on and so forth. What is the data for using parenteral nutrition as a bridge for EN? I hope we covered a lot of that in the talk today, kind of when to use enteral nutrition, when to use parenteral nutrition. I really comes down to this in my mind. If you have a severely malnourished patient and they can't have oral or EN, you can use parenteral nutrition. Especially if it's a condition that's likely going to get better over the next week, 2 weeks, 3 weeks, to where you can transition over to EN or oral diet. So I'm always thinking, use the gut if we can, but if we have a malnourished patient that has a lot of other problems going on, we definitely probably want a bridge of parenteral nutrition. Next question is, how do you recommend to educate physicians when they are using PN inappropriately? Oh, wow. Well, that's a great question. And I think that a lot of physicians don't, believe it or not, most of the physicians are not trained in nutrition aspects, but they also don't want to be wrong, because that's their ego and that's just the way it is. So I think that in general, you might want to address it as, hey, this patient might need parenteral nutrition, but is there a chance we could use the gut so that it doesn't stop working? And if we can use the gut, why don't we use it? And that's one way to bring it up and ask what they think and go from there. But keep in mind, like I said, that it's tougher just because they don't have as much nutrition background as we would like. I mean, as educators in medical schools, I'm the only one at Mizzou that does this. There's not a lot of people that have a nutrition champion that's able to educate the docs on this stuff. So kind of just keep pushing them and keep moving them forward, and ask in a gentle way. Doesn't embarrass them too much, because they definitely do not have the full knowledge on nutrition that most folks will have, as the dietitians and the nurses who deal with this every day have. What about NG feeds for patient on a rotoprone bed? Well, that's a good question, and that could be an issue, at this point, because you definitely want to kind of avoid all the problems associated with that, like aspiration and stuff like that. So that's a great question, and you may have to try something different. You may have to go with NJ feeds to try to keep them from aspirating, especially if they have other lung issues and injury already. What is a common rate to initiate enteral nutrition? Oh, that's a good question too. And the answer is yes, 100% sure. It all depends on the patient and their likelihood of tolerance to the enteral nutrition. Now, we all know trophic feeds seem to be better than full feeds based on Todd Rice's study in Vanderbilt, and the Eden trial. So I think that definitely start at a low rate to start with, and always monitor for gastric intolerance. Thanks for having me. I appreciate your time.
Thank you so much for joining us today. And on behalf of the Nestle Health Science, we hope you have a fabulous afternoon and take care.